Teresita Gabriel.
Wow, I like that ever gorgeous part. Thank you very much, Dr. Dena,
Yes,
for
doctor.
your very gorgeous introduction. Okay. I still remember that in the past, I used to have a face-to-face encounter with the Philippine Association of Family Medicine and missed that a lot. And I hope that in the future we can do that again. I'm so opportune to have been invited once more by your society, and I'm glad that Menarini also agreed to have me as their speaker. So let me share my slides. Let's do it a little interactive. Can you see my slides? There. Can you see my slides? Hello?
Yes, doctor.
Or we can.
It's visible.
Okay. So I chose the title Red Room of Itch, and as you all are seeing, I'm wearing red. My lipstick is red, and the world of dermatosis. Okay. So this is the overview of the topics that we will be discussing. So when you look at eczema, it's the same as dermatitis. It comes from the word exane, which means to boil, a highly individual condition that comes in many different forms. Dry, scaly, red, itchy. It can be chronic, it can be acute. So if it's acute, it's weeping, crusting, and even bleeding. But unless it's secondary infected, it's not contagious. And when you look at dermatosis, it's any lesion on the skin. So here is the first part. So you have 20 seconds. There will be a poll. Then you have to choose which is a case of nummular dermatitis. And I call this part the itchy circles. So please put in your answers. So 10 more seconds. Not minutes, huh? Okay. Oh, so the answer is letter C. Let's see if you got it right. I think you did. Yes, because letter A is pityriasis rosea, letter B is tinea corporis, and letter C is nummular eczema. Now, when you look at nummular eczema in this red room of itch number 1, it's a chronic inflammatory skin disorder. It has papules, papulovesicles, so kind of whipping, coalescing into coin shape, oozing plaques with crusting and scaling. Etiology is usually unknown. Now, you can treat it either with your topical corticosteroids or a combination of your steroids or antibacterial, depending on the presence or absence of secondary bacterial infection. Red room itch number 2, it's tinea corporis. It's any dermatophytosis of the glabrous skin except for the palm soles and the groin. It could be transmitted directly from infected humans or animals or fomites or autoinoculation. Occlusive dressing, occlusive clothing, humid climates are all associated with more severe eruptions. And you usually call it ringworm because it looks like a serpiginous plaque with scales across the entire active erythematous border. So you may opt to give oral or topical antifungal agents depending on the severity of the condition. So if it's on the face, you call it tinea fasciae. If it's on the inguinal area, you call it tinea cruris. If it's on the hands, you call it tinea manum. And these are among the laboratories that you may request. I'm sorry, if you want to confirm your diagnosis, you can do KOH. If there's some doubt, you may do culture and some other tests. Biopsy for the deep fungal infection, that's when it may help. But clinically, with the picture, you'd be able to diagnose your tinea corporis. So here are the oral antifungals that you may give for your tinea corporis or cruris. And the dosages are there. Now, it says here in this textbook, itraconazole 100 milligrams per day for a week, but I can extend it to as long as 2 weeks, depending on your follow-up of the situation. And for you, tinea pedis and manum, you have to give it for a longer period of time. The itraconazole now becomes twice daily, not just a week. For other patients of mine, I give it as long as 2 weeks. So this is just an overview of the various topical antifungals that you can choose from. Imidazoles like ketoconazole, miconazole, clotrimazole, and allylamines, which is your terbinafine. Okay? So, red room itch number 3, which is pityriasis rosea. It's common self-limited papillosquamous eruption that lasts for 5 to 8 weeks. Self-limited, but I usually treat it. I'll tell you how. It begins as an oval isolated plot, which you call an herald patch that contains some colorate fine scaling at the periphery. Then there are secondary eruptions that come, smaller lesions, explosive in the trunk and proximal extremities. So you will get a history from the patient like, I have these eruptions in a couple of weeks, just 1 or 2 weeks, and it's all over. And the most common misdiagnosis is your tinea corporis. Remember that you don't get explosive or many lesions of tinea corporis in a week or 2. It has to be slow before it becomes this plenty. So it can have associated systemic symptoms and pruritus, but many cases are asymptomatic and most likely related to some form of infection. But this is just 50% of those conditions seen in the journal. So the treatment is usually supportive and reassurance is needed. For in some textbook, they would say severe cases, acyclovir hastens recovery. But in my practice, I would give not just topical steroids and antihistamines, but I would give a short course of oral corticosteroids. Because if you would believe in the term that it will resolve in its own, your patients will dissolve because it will not resolve on its own. Sayang, you should have been here in front of me so that I can see your faces. So we go to question number 2, which is footloose. Which do you think among these pictures is caused by dermatophyte infection? So can we have the poll? Then I'll give you again 20 seconds. So 10 seconds more. Okay. And the answer is letter B. Let me see my pictures. Caused by dermatophyte infection. Oh, I think you're right. The first picture is dyshydrotic eczema. The second is tinea pedis. And the third is contact dermatitis. Looks alike, right? But, oh, sorry. I lost my face there. Red room itch number 4 is your tinea pedis. It's a dermatophytosis of the feet. So it could be interdigital. Some would be like moccasin type, which is very thick. Some would be vesicobulous, like more weeping. And some can even be acute ulcerative and predominantly caused by your rubrum. And how do you treat it? If it's this extensive, I will tell you, I have to give an oral antifungal. Now, it's so erythematous. So in the first week, you may combine your topical steroid, even your antibacterial if there's secondary infection, and your antifungal. Then you give also an oral antifungal. Of course, if it's itchy, you give an oral antihistamine. So again, I've shown this in my early slides. So just to remind you, you can take longer, twice daily for your itraconazole for 1 or 2 weeks, or terbinafine for another 2 weeks. Okay, and I've shown this also in the previous slides. So red room itch number 5 is your dyshydrotic dermatitis. It's like deep-seated, clear tapioca-like vesicles or like sago grains. It's usually on the fingers, palms, and soles. It may sometimes have like blisters, bullae scaling, fissures, and lichenification, or what you know as thickening. Then the treatment is a higher or a more potent topical corticosteroid because the palms and soles are thick. And in cases of secondarily infected lesions, you can give steroids and antibacterials. Red room itch number 4 is allergic contact dermatitis. Look at the symmetry and look at the area that's affected. When you look at allergic contact dermatitis, it's due to an environmental allergen. It's usually delayed type. So you need previous sensitization. So the acute phase would start with pruritus, erythema, edema, vesicles, just like any other acute conditions. And the chronic, it becomes thick, like canified, fissured, and even pigmented when it's healing. Now, how do you treat? You treat the same way. You have to give, if there's like this erosion, a combination of your antibacterials and topicals, corticosteroids. But if it's so swollen and edematous, then you can give an oral antibiotic as well. So this is another example that I want to show so that we are able to compare the difference between allergic contact dermatitis and irritant contact dermatitis, wherein you don't need to be sensitized with irritant contact dermatitis because this is due to exposure to more irritating substances. At first attack, you already have the erythema, vesiculation, because it's caused by your acids or alkalis. So it can even burn or cause necrosis. And it's usually limited to the site of contact with the irritant and really appears a few minutes or within 24 hours after exposure. Treatment is the same. So this is a comparison of the symptoms of your allergic contact dermatitis and irritant contact dermatitis in a nutshell, wherein your allergic contact dermatitis would be spreading from the site exposure to the periphery, or it may even become generalized. However, your irritant is really sharply confined. Then you may have the acute or the chronic forms for both. Evolution of irritant is more rapid compared to your allergic. And of course, the irritant is dependent on the concentration of the agent. However, allergic, as I've said, since its sensitization would not really depend on the amount that is applied. Okay? So, let's now go to question number 3. Hair today, gone tomorrow. Which do you think is a sexually transmitted infection? Can I have the poll? Okay. Okay. Okay, the answer is, most of you got it correctly. And why? So let's see. There. The first picture is a picture of a moth-eaten alopecia of secondary syphilis. So there is alopecia patches in cases of secondary syphilis, which is a sexually transmitted infection. The second picture is Pinia capitis. And the third is a picture of alopecia areata. Okay, so what is secondary syphilis? It's caused by your Treponema pallidum. And there are different stages. You have a painless erosion on your genitalia, which is a primary chancre. Then this is one of the secondary lesions that you can see in secondary syphilis, which are skin eruptions with or without lymphadenopathy and organ disease. Then you proceed to your latent period, which is variable. You may probably have no signs and symptoms of the disease, but you have a reactive serologic test. Then your tertiary is different. You get these gummatous lesions, the ulcerative lesions, or worse, you get neurologic signs and symptoms and cardiovascular manifestations. So what are the points to remember? When you see patients with something like moth-eaten alopecia, maybe you want to look at the sexual history and you want to ask for a past history of lesions of the genital area. And as I've said, chancre is usually painless. And most commonly affected when patients have secondary syphilis are the palms and soles. So you try to look at the palms, but no, don't hold it, just look. And other dermatological manifestations can be investigated. Also, as I've said, this is an example of moth-eaten alopecia. Now, Roseola syphilitica is like a viral infection. So if you don't have any idea that secondary syphilis can present with this kind of copper-colored macules, then you probably will be confused. And misled into thinking that this is just an ordinary hypersensitivity reaction or viral infection. So you have to have that as one of your differential diagnoses so you know the right questions to ask. Okay? Then, as I've said, you have the involvement of the palms and soles. Erythematous to copper-colored papules and macules on the palms and soles. So not all lesions on the palms and soles is erythema multiforme. It can be secondary syphilis. Nickels and dimes, you can also have this. So I hope that you don't misdiagnose this as a case of tinea fasciae. Be very careful. Maybe if you need a friend, you can. Before, when we were all together, seeing eye to eye, I would tell you, if you need a friend, it's 0918-945-7425. And that's my phone number. I will give you back your patience. So mucus patches, you can have involvement of the mucosa in your secondary syphilis. So the reason why I'm showing you all of this so that you would know how to look at all your patients, all the physical examination findings, so that you're complete. And in the anal region, you may have this verrucous plaques, which is known as condyloma lata. Okay. So, if you are dealing with a patient with secondary syphilis, then there's a different approach. You have to request for your VDRL, quantitative. You have to request for that, or RPR. Or more so, you have to request for a treponemal test for confirmatory. This is very important because at the end of the day, the treatment is different there. So, treatment depends really on the stage. More or less, whatever the stage is, the treatment is benzathine penicillin. It's just a matter of giving it at different doses and having different monitoring system because usually you will monitor the quantitative drop in your VDRL and your RPR. Once the treponemal test is positive, it's going to be positive forever. So you're not going to use it as your basis of monitoring. Okay. I hope you got a picture already because I will not say it one by one. Then if you're allergic to penicillin, then you will have to give them the alternative treatments. Okay? So let's go to tinea capitis. Look at the scales. It's really very scaly compared to my next slide, which is really very clean. So if for some reason you have this kind of patient, you've given all the oral antibiotics, all the topical corticosteroids, and you even gave oral corticosteroids, maybe you want to think of tinea capitis as a differential diagnosis. Although common in children, 3 to 14 years of age, it doesn't mean that when you're an adult, you're exempted. And there are many types, non-inflammatory, black dot, and inflammatory. So that's black dot when you lose hairs. Then you have the baggy type there, wherein you're going to have hair loss. It's going to be a scarring type of alopecia. So you had better be sure of your diagnosis because you would have to give your patient an oral antifungal. So there, for your tinea capitis, aside from giving your antifungal shampoo so that you prevent the transfer of the fungal infection to the rest of the family members, then you would have to give an oral antifungal. No topical antifungal will take care of your tinea capitis. But of course, if there's secondary infection, you can always give your antibiotics. Okay, here is other topical antifungals which you might want to use for your patients. Okay, so let's proceed. So dermatosis, we're down to dermatosis. So this is alopecia areata. It's a non-scarring hair disorder and it occurs in both genders equally and it can affect any age group. Most common form of hair loss in children. Well-demarcated, round or oval, clean patches. Really no scale. No? There, 5% develop hair loss, but 1% may even be totalis. or universal. Sorry, 5% is totalis and 1% is universalis. And there are sometimes nail changes, but not all the time, like nail pitting and sandpaper nails. This is an autoimmune condition with a possible hereditary component. It may coexist with your other autoimmune disorders like your thyroiditis or your vitiligo. So, for your purposes, if you get a patient with localized, you may start with the potent topical corticosteroids. Or if you know how to do it, you can do intralesional corticosteroids. We usually shy away with giving oral corticosteroids because there's a rebound. So as again, if for some reason your topical corticosteroids doesn't work and your intralesional corticosteroid doesn't work, you can call me because we are friends there. So now we go to question number 4. This is a 55-year-old patient that a female and 60-year-old male with a 10-year history of multiple very pruritic hypopigmented patches on the trunk and back. The treatment given were oral and topical antifungals, topical steroids, and topical calcineurin inhibitors. So what is your diagnosis? And here is the poll, which have been shown to you while I was talking. So by that time, you must have known the answer already. So, the most has answered tinea versicolor. Remember that the patient already received oral and topical antifungals. And if you're talking of tinea versicolor, it's a fungal infection. So, the winner is 31% mycosis fungoides. Why? So, let's see. Dermatosis room number 4, there is such a thing as hypopigmented type of mycosis fungoides. It's a CTCL, it's a cutaneous lymphoma, and approximately 40% of all cutaneous lymphoma. It usually arises from mid to late adulthood with a male preponderance of 2:1. And it has different stages, the patch type, the plaque type, the tumor. This is a less common manifestation, but it's nice to know that this kind of lesion exists. So what are the points to remember? Age group, no response to all the previous medications. It's severely pruritic, and it's also in non-sun exposed area. And it's not even scaling. So this is the scoring. I just wanted to share to you the scoring system for your early mycosis fungoides. It's really very complicated because you need clinical, histopathologic. But I think the lesson that we want to convey here is that when in doubt, you should refer, and that we can do the biopsy. So biopsy would be very pathognomonic because there's what you call the Potter's microabscesses and atypical lymphocytes in cases of mycosis fungoides. And this is gold standard. And we also do some immunologic markers to be sure it's CTCL. So treatment in early stages, there are different treatments. Some would give topical corticosteroids, but as I've said, it has already not been given. There's also what you call phototherapy. Then there's also immunosuppressive agents. But I think I would rather hear from you so that we can talk about your patient. Prognosis really depends on the stage, presence of lymph node involvement, and presence of visceral disease. So dermatosis, room number 5. It's an autoimmune common that causes depigmentation, means absence of pigment. It's multifactorial, genetic, predisposition, autoimmunity, and environmental factors, and increases risk of other autoimmune disease, but decrease risk of skin cancer. Okay? So reversible with treatment. If it's extensive, you can refer to areas wherein there's phototherapy because this is really a difficult thing to do. We also have for localized, we have targeted phototherapy. Of course, initially, it's only localized in certain areas. You can still give your potent topical corticosteroids. And again, because we're friends, you can always refer to me. So now we go to our dermatosis room number 6, which is your tinea versicolor. caused by a fungal infection, usually seen. It's also on the covered areas. So that's probably why you thought it's tinea versicolor, but it's more scaly. And you have many types of tinea versicolor. You have hypopigmented, hyperpigmented, and you even have erythematous type. And it's mildly, but not as severe, pruritic, mildly pruritic compared to your mycosis fungoides. And it's usually on the covered areas of the skin because that's where it sweats. Salmon colored at some hyperpigmented, hypo, or even erythematous. And you can give shampoos, second line, but this is in the textbook. But I give for my patients, I also give oral itraconazole for my patient for 2 weeks, once a day for 2 weeks. Okay, so let's go to question number 5, which is bubble trouble. Which do you think is immune-mediated condition? There. So do we have the answers? Oh, actually, BNC is correct, but my answer is supposed to be letter, wait, sorry, there, letter C. Why? Because of the site of predilection. It's bullous pemphigoid. It's a pruritic tense blisters on a background with urticarial plaques. You see that it has been there for months, but your patient has no systemic signs and symptoms. And it's usually located on the extent, on the flexors of your patients. It can even be all over for the more severe conditions. So you have to do biopsy and you have to do autoantibodies because the autoantibodies are direct to certain proteins that gives a clip. That's why there's blistering. There is how it would look with your DIF. There is their complement and IgG that's deposited in epidermal basement zone. That's why there's a split and you see the blisters coming out. So this is really so complex. So if for some reason you get a patient like this, please refer. Okay? So now we go to the next part, which is the various benefits of topical corticosteroids if you know how to use it. Because it's an anti-inflammatory, anti-proliferative, and immunosuppressive. And before using different types of topical corticosteroids, I think you should know the ranking. So, because this will be the basis of your steroid-responsive dermatosis. Super potent is here. That means it's the strongest. So that's class 1. Then followed by potent, your potent upper mid-strength, and your mid-strength. And your class 5, 6, and 7 is decreasing in strength. Your least potent being the hydrocortisones and your prednisolones. When you look at potency, ointment is more potent than cream. Okay? So now, what is the classification of dermatosis? You base it on response. Because there is highly responsive, which means you might need a lesser potent topical corticosteroids and it's going to improve. Moderately potent, you need potent would be fine. Least potent means you would need a stronger preparation when you look at these kinds of conditions. So when you look at intertriginous, because intertriginous, those are thin areas. So those are highly responsive dermatosis. Just like this patient who has a very erythematous patch with whitish scales, this is intertriginous psoriasis. Now next, we all know atopic dermatitis. This is another lecture. It has a site of predilection, antecubital, popliteal, you have dryness of the skin, you have eyelid dermatitis, you have even nummular eczema and prurigo nodularis. So atopic dermatitis in children is very responsive to topical corticosteroids. Seborrheic dermatitis as well. When you have a case of seborrheic dermatitis, which is on the face and on the scalp of children, this could be highly responsive to your topical corticosteroids. Of course, it would really depend. If it's so crusted and so thick, then you would want to use a more potent topical corticosteroids. Intertrigo, opposing areas would give you some erosions, erythema, and it is very responsive to topical corticosteroids. So you have this type of intertrigo in children and intertrigo in adults. So moderately responsive plaque type psoriasis would be responsive, but if you want to hit it hard, you may always start with the more potent topical corticosteroids, then lower down when it has already flattened to a moderately potent topical corticosteroid. Atopic dermatitis in adults would be moderately responsive. So as I've said, it has more or less the same site of predilection, except that in children, it's really more on the cheeks. Okay? So papular urticaria just means bites from your insects, bites from your mites, and this is moderately responsive to your topical corticosteroids, usually common on the legs and arms. Nomular can be extensive. You can have nomular dermatitis with your ED reaction, just like in this case, wherein you might need to give a short course of oral corticosteroids, and because it's weeping, you might want to give a combination of your topical corticosteroids and antibacterial. Okay? Irritant contact dermatitis, this one is from Paltis. So it's so erythematous and edematous, maybe you can give a combination of topical corticosteroids and your antibacterial. And of course, if there's cellulitis, you can give oral antibiotics. Now, lichen simplex chronicus simply means it's a chronic form of eczema. That means you might want to give the most potent corticosteroid. There is a combination of your potent topical corticosteroid and salicylic ointment in the market. And with this, I think it will benefit from this because it's really very lichenified or hyperkeratotic. Least responsive areas like the palms and soles are least responsive. So that means if you're dealing with the palms and soles like this one, which is secondarily infected, use a potent topical corticosteroid with your antibacterial. Granuloma annulare is kind of rare, but it's not like your nomular eczema that it's weeping. It's dry and the borders are papular and elevated. And it really needs a very potent topical corticosteroids, but because of the rarity and the difficulty in treatment, you might want to collaborate or refer this to your favorite dermatologist. 0918-945-7425. I'm almost done. Allergic contact dermatitis. This one, you see, it's obviously from the slippers, the way it looks, and it's secondarily infected. So topical corticosteroids and antibacterial. And you might have seen cases of discoid lupus erythematosus. You see, it's very erythematous. There's follicular plugging and there's some atrophy. And again, this is kind of difficult condition to treat. So let's refer. And psoriasis of the nails. There's a lot of treatment, very potent. We occlude your potent topical corticosteroids for these patients with psoriasis of the nails. But of course, it's not just psoriasis of the nails that we want to treat. If it's really extensive, there's a plethora of treatment for more difficult cases of psoriasis. Least responsive palmoplantar psoriasis, not just topical, but it really needs a systemic treatment for these kinds of condition, not just potent topical corticosteroids or your antibacterials. And again, we've already discussed it a while ago, pityriasis rosea is one of the least responsive conditions. And this is insect bite or prurigo simplex. So there are two terminologies. Some would like to call it papular urticaria. Some would just want to call it prurigo simplex. And this, we've already discussed, immune-mediated would need systemic treatment. This is a case of bullous impetigo. And this is violaceous plaques. So if for some reason you've been treating patients with this kind of conditions and it's not improving, maybe we can do biopsy for lichen planus. And this is a case of necrobiosis lipoidica diabeticorum, which is maybe associated with diabetes mellitus. And it's usually on the legs. It's atrophic, it's telangiectatic, and it would need the opinion of an expertise for us to be able to diagnose because we need to do a biopsy. And so the principles when you initiate topical steroid therapy are initiate the lowest potency to sufficiently control this disease. I've always told you in the past when I was lecturing face to face that I really don't use too much of the age, but I use the severity of the condition. If for some reason a child has a very thick plaque on the arms, I will not hesitate to use a more potent topical corticosteroid. So avoid ulcerated or atrophic or prolonged use of potent agents. Avoid high potency preparations in infants and young children, especially long term. Treat with low to medium potency preparation for larger surface areas if you're going to use it for a long period of time. And highly responsive disease will respond to weak steroids, whereas less responsive disease would need a more potent topical corticosteroids. So these are among some of the adverse drug reaction if we do not use our topical steroids properly. But I'm sure you all know how to use it properly. Okay? And you can have easy bruising. So how do you avoid systemic absorption? You should not use, sorry for the weeks, it's plural, not more than 45 grams per week of a potent steroid and not more than 100 grams per week of a weak or moderately potent steroid. And for special population, no correlation between the use of topical corticosteroids, congenital abnormalities, and pre-delivery or stillbirths was seen, except that it may increase the risk of very low birth weight if you give very potent topical corticosteroids, high dose. There, no adverse effects during lactation unless you're applying it on your nipple and the baby will suck the nipple. So I probably know you won't do that. Okay? Then geriatric, because of the thin skin, has a high propensity to develop your adverse drug reaction. So be very careful with your choice of topical corticosteroids for geriatric patients. And avenues for your combination, you have an infected seborrheic dermatitis. Look at the adult patient on the right. It's crusted. When you have seborrheic dermatitis, that's fungal. So you need antifungal. And you have the erythema, you need topical corticosteroids. And for this condition, you would need a topical antibacterial. So the triple combination would benefit from, the patient would benefit from that triple combination. On the left, you have a patient who is a child who has a erythematous seborrheic dermatitis. So, and I think there are some erosion. So the patient can have your topical corticosteroids antibacterial. So this one is an infected nummular eczema, topical corticosteroids antibacterial. Here is infected stasis dermatitis. So you can use topical corticosteroid antibacterial, but more often than not, you get recurrent cellulitis among patients with stasis. So you might want to give your oral antibiotic. So this is an infected Taenia pedis. So it's erythematous. So in the first week, it's erythematous, it's eroded, and there's fungal. So you can use for a week your triple combination, then shift to your monotherapy antifungal after a week with this kind of cases. Infected hand eczema or your, I don't think it's a housewife's hand. So you can use your combination topical corticosteroid and antibacterial. Oh, that's it. Thank you so much.